I don't know you because I used to call on Dr. Ibrahim.
What's that?
I used to call on Dr. Ibrahim's office for eloquence. I'm surprised I don't know you.
Really?
Yeah, yeah,
Edward
yeah.
Thomas?
So I
Yeah.
probably because that was the territory was kind of split right there where his office is on Belfort Road. So maybe I was in more. Maybe you saw the South person more than you saw me, but yeah. We're great to meet you in person.
Yeah, nice to meet you. And we got Doc here himself, and then the computer was previously on Gabe, who's our CEO. I've got
Okay.
Jacksonville Regional Director Natalie over
Hey
here.
Natalie, how are you? I
And I
talked to JT Spears out in the Panhandle earlier this week. So he told me that he's had some good experience with Premier Cardia out that way. And so we're starting to kind of grow in this space over in Jacksonville. And I was literally here because we're launching in the VA here in Puerto Rico and Menonita Hospital and Orlando Health here in this area. So we're growing, expanding. So I'm going to let me know if I'm speaking too softly, trying to be courteous. I'm going to share my screen and just kind of go through a couple slides. Feel free to stop me and ask questions kind of where needed. I kind of know some general questions we typically get. So I kind of go from there. So give me 1 second. Share my screen here. Oh, can you give me permission to share my screen?
ooh, I don't know. I can make you a host. Let's try that.
Yes, do that.
All right. So
Perfect.
did that work?
Yeah, let me see. Let me check it. It's so hot here. Oh my goodness. Share screen. Start the broadcast. All right, let me go here to my photo. So I am going to start. Well, let's start right here. So Furoscix has been a game changer in cardiology and nephrology because for the first time when it comes to managing edema, volume overload due to CHF or CKD, it allows you to be proactive and preventative. And what I mean is that for the last 20 something, 30 odd years, it usually has been symptom related, where a patient says, oh, I can't put my shoes on today, or my belt, can't put my belt on, or my rings are too tight, or I've gained 5 pounds, or I'm having trouble breathing, I can't lie down. They call. They can either call the doctor's office, they call the nurse and say, hey, I've gained some weight, I feel bad. What can you do for me? The issue is that by the time a patient has symptom recognition, they've been in heart failure for 14 to 21 days. So we already have a ball kind of rolling downhill. And so we're going to escalate the orals, right, to try to get the best effect for the least amount of horsepower. The issue is with high gut edema, they just don't absorb the same. Like for instance, oral furosemide can be 100% when they're euvolemic. It can go down to as low as 10% absorption. So now we'll say that the fluid is steadily elevating or we're escalating, and it's not enough. Furoscix, because it's sub-Q, you're bypassing the GI tract and going right into the bloodstream for a patient with 99.6% bioavailability, almost the same as an IV for a patient. It works really, really fast for them. You're talking about you're going to start to urinate in about an hour for that patient, right? You're going to offload about the same amount of fluid as you would with an IV in the hospital. But the biggest thing is that this is meant to be done by the patient or a caregiver at home. For the nursing home, the nursing home, it is great because you don't have to have an RN, LPN, and APP do the administration because it can be put on and applied and done by any tech there at the facility. So now kind of go back into so I normally have a demonstration kit. I don't have it because I came to the airport security today. I had to put it in my bag, but it's pretty easy to do. There's a bunch of prompts we have on the device, and we always have these instructions for use for the patient. But it's 3 steps, literally, right? The device looks like you see here, right? You open the device up, you load the medication. It can only go in one way. You close it, you peel the Bluetooth exposed adhesive and pull it on that belly, and you press the button, and the device works. Again, it's gonna start to urinate in about 45 minutes to an hour for that patient. Here is kind of what makes Furoscix really, really cool. So our product was approved by non-inferiority study. It was an open label study with a 1 week washout period where people were given in the first phase. They all were given IV Lasix. They were given 40 BID 2 hours apart, right, to see what the full offload would be. Then they were off on nothing for a week, and they were given Furoscix knowingly to see what the outcome would be. What's different about Furoscix is that it's a computerized delivery system. It is literally a slow drip IV. It is 80 milligrams given over the course of 5 hours for that patient, right? So it's 80 milligrams and 10 milliliters. But it's so cool because what happens is in the first hour, if you see that blue line right here, you get 30 milligrams delivered to activate the kidneys, right? Then for the next 4, you get 12.5 slow drip over the course, right, of those next 4 hours to have a very, very high steady state. The issue with IV and even IM Lasix is that it's very fast acting in a very short half-life. So high peak and low trough for patients. With Furoscix, right, because you have the very high steady state in the same area under the curve, you're able to give this little bit of dose of 80 milligrams, which even compares up to 160 milligrams IV because of the efficiency and offload the same amount of fluid. Going to the next slide here. What you see is fluid offload. The blue line being Furoscix, the teal line being IV Lasix. Same fluid offload, about 6 to 8 pounds in 24 hours for that patient with this device. And what's great about it too is that you're offloading that weight in 4, 5 to 6 hours, not in 45 minutes, so less risk of hypotension for that patient. It's phenomenal. Also, too, you have the same amount of natriuresis. So this literally is your RN, your IV bag, your IV line in the box right there. Again, it starts to work in about an hour for that patient, and they will offload 4, 5, 6 pounds within that 5 or 6 hours typically. And as far as my big thing here is, you know what they look like. You know, when they present right here, I always say, when I'm in an office, you're going to see feet like this at least 3 times today. And you're going to get the phone calls with a little scale saying, hey, sugar, I've gained 2 pounds. What can I do? Miss Betty, but Miss Betty's calling. 2 things happen with Miss Betty who calls about that 2 pounds. 1, she's lying. She's gained 6 pounds because she's afraid to go to the hospital. Right? And then 2 is we're going to escalate them kind of orally, hoping they're telling the truth. And it may or may not work. And so it may take 1 more meal, 1 more stressor to have that person go into full hypervolemia, have to be hospitalized. So any questions for me?
I have a couple questions. Can you hear me?
Yes, I can.
I have a couple questions. Is 80 milligrams the only dosing that's available?
It is. So the reason why is that we actually did a couple studies. We compared the 80 milligrams. It's equivalent to 80 milligrams PO, but also we compared that to up to as high as 160 milligrams IV for a patient, and just found that it's so efficient that it's been phenomenal for HEP patients. HEP patients is extremely efficient. So we haven't had a need to go to multiple doses as of yet. Even with ESRD patients, if they can produce urine, they're good to go on this device. But it's a single dose device right now. I will tell you that if there is some concerns about like being able to customize for you, write this down. This is how the device works. In the first hour, somebody take notes. You get 30 milligrams. Hour 2, you get another 12.5. Hour 3, you get 12.5 more. 4, 12. You get where I'm going with this?
Yeah.
So yes. And so there's people that do all kinds of things to where it makes sense. But we found this, there is no, so because we have the CKD label now, there's been no, compared to oral, there's no difference in the metabolic panel, electrolytes loss. It's the same as an oral medication. And that is because you're offloading in 5.5 to 6 hours, not in 45 minutes. So you're not really straining and stressing those kidneys. What you laughing about there, D? I see you.
Yes. Total side note, but actually I did want to ask about for CKD considerations. You said
Sure.
about how you guys got approval. That's been my biggest question. You know, a lot of these
Yes,
home patients, so fragile. So can you speak to some of the CKD considerations for our group?
sure, absolutely. 1 second. Let me go ahead and come off of here. Go something else. So give me some concerns about CKD that you have. Would it be, so our only issue with CKD, really don't have one, the country indication list, is can that patient produce urine? So we have patients with as low as 20 for EGFR production. So they can produce urine, they're kind of good to go, stage 1 through 5 and ES RD for them. The thing that what we love about when we talk about just the CKD itself, this is kind of my picture of the whole gut mucosa. And when they get full of food, they kind of close up and nothing absorbs when you're hypervolemic, right? So your oral blood pressure medications don't absorb. None of your oral diuretic may absorb because there's just too much fluid in there. And so now she may be given 80 BID of Lasix, but it may only be getting 40. So you can't catch up to the weight that's kind of being gained, right? And even one of our studies even showed patients they were on torsemide and Benadryl. At a certain point, there's too much volume; they can't even keep up. So they end up going to the hospital anyway.
And because of some of like a little bit of slower delivery, not such a massive insult to the system, kind of right off the bat, maybe a little bit less harsh on the
Yes, right. So here's the most important part. So we consider a CKD patient, and I kind of talked to you about what I've learned thus far. And we have the most nephrologists writing in the nation, in our region in Florida and Mississippi, Alabama. And so the big thing is that what's so important is that you're talking about progressive disease in class 2 to class, stage 3 and stage 4, is that with furoscix, right? So say you have a CKD patient who's becoming hypervolemic, and you may, as opposed to having to put that patient on 60 BID of Lasix or maybe 40 of Bumex, whatever it may be, you could actually stay in the weakest loop, furosemide, use furoscix to get him euvolemia and keep that patient on a very low dose of the loop, because if you keep on a low dose of the loop, what it does is it kind of helps to retard that progression, right? The higher and stronger the loops are you give them over time, the faster they progress to ESRD. So we have the capacity to literally have a patient who may have been on 20 or 30 QD of Lasix, and they've gained like 3 or 4 pounds. They're having shortness of breath, right? You know what? We're going to cessate from the Lasix for a day or so. Use this, offload 5 or 6 pounds, and go back on that maybe 15 or 20. That's the beauty of it, right? Here's the thing that's really important when it comes to your CKD patients. It is, you see them and you see their legs are puffy, they're tight, the blood pressure. How big of a concern is that when you see a person who's in fluid overload with CKD?
with the blood.
Yes.
Usually pretty substantial, depending on the different kind of sniff versus inpatient rehab versus LTAC.
Sure. So we always say this, right? Because we start to work in an hour, give me an hour, I can reduce that blood volume. Reduce that blood volume, I reduce that PVR, and guess what the BP does? It goes down. And so the great thing about that is if there's a patient who happens to be on GDMT, you don't have a risk of them coming off all their meds and they have to go to the hospital. It's a huge benefit, but we don't have any additional considerations. The biggest thing is being proactive with that patient and kind of trying to catch that patient early. So we separate CKD in a couple cohorts. One of them is the people that they have these flares all the time, right? And you're like, you know what? Or they just happen to show some peripheral edema. Don't wait. Use this device. Another thing too, it's hard to focus on people here in the airport. So,
like you're putting on a show for everyone.
Yeah, I know. They're like, what is that guy talking about in that crazy suit over there, right? Another thing too, when it comes to CKD, and it just depends on, especially in the nephrology world. Have you guys heard of the CKCC, the value-based care for nephrology patients? CK. So what it is like a capitated. Every time they go to the hospital, that comes out of the practices or their budget. They pay for their entire stay. And we have the capacity to keep these people out of the hospital with this device. A lot of our people in the CKD space have nephrotic syndrome. We're indicated for that as well. And overall, our indication is for peripheral edema, or edema due to either CKD or CHF or just edema. Hep ref, combo, it does not really matter. HOCM, anything to do with heart failure, CKD, volume overload, we're approved for right now.
What's insurance look like for these nursing home patients?
It's a great question. You had it queued up for me, huh? So
Yeah.
most of the patients are Medi, and so right now it may be a competitor. Most of our nursing home patients have gotten in Jacksonville from their competitor. Is Cardio Renal Vision a competitor of you guys?
Mm-hmm.
All right, so there's none over there, works over there in nephrology, Sister Immaculate. Yeah, you guys know her?
Yeah, but she actually left their group. She's not with them any longer.
Oh, she left. Huh, I didn't know that. Just talked to her last week.
Yeah.
You guys hired her away?
No.
Oh, dang.
Not
Okay.
her.
So most of the copays have been $0.
Okay.
And so here's the thing about it though. What we do, so going back to the prevention portion, what we do is we typically order 10 units. The reason why is 10 units is because the copay is a flat copay. You can pay $10 for one, or 0 for one, or 0 for 10. If a copay happens to be $4 for a patient, for some people that's a lot of money, right? Get the 10 for the 4. Product has a 2-year shelf life. 2 years, right? Most people, if we catch them, go back to here. Love this. When you see this fat foot, big ankle, right? Cankle, you see that fat foot? What they call, because they gain, sugars gain 5 pounds, right? They can't lie down. You got to catch them there. You got to intervene right there with that device. You catch them here, usually 2 or 3 days is going to be enough for that patient. And then you go back on the orals right away. And so the next time they have an episode, it's already there. For a sniff patient, it's important because they may have a flare while they're there for the short stay, but when they go home, it goes with them. We teach all patients, when you go on a cruise, you take 3 of these with you. You go see a little June bug, and you're going to eat your chicharrones and have your beer, you know what I mean? You will 2 or 3 of these with you because they always get in trouble at 7 o'clock at night and the weekend, right? When I said about preventative and proactive, that's the biggest thing, right? When it comes to hospitals, we're trying to prevent the admission, not just the readmission, but then it's a quality of life thing because they have the power. I would say the power's in their hands to actually put the device on and press the button, and you can go pee in your restroom, not the hospital bedroom or not the emergency department. It's a great tool. Sorry I don't have everything because of this whole trip here, but I would love to come by and get you guys on the portal. You have an MA there in your office, right?
Yeah. Yep.
So I cover the whole region. So I'm going to show you something, kind of how we do the orders. It's pretty cool because we already have one for your group, and so we use a specialty pharmacy, and it's a pretty cool hub. I'm going to log out and pretend I'm a provider. Use the dummy hub here.
So just to be clear, this is not an order that you can put in through the sniff of like their PCC and
no, we do not. No, ma'am. That's illegal. So we go through the patient's Part D benefit for Medicare, and so they can have outside meds or specialty meds delivered. That's what we're doing at all nursing homes, and we have our own specialty pharmacy in the hub. Let me show you this real quick.
I can speak on how I've done it in our nursing homes. Furoscix is in PCC. However, since I use specialty pharmacies, it's delivered through CareMed when I order it online on their website. And what I've worked out with the DONs and the administration team is we have done select training with them, and they keep the boxes in their office. So if it's administered, they pull it, since each box is not individually labeled like when it comes from their pharmacy. So it's FedEx to the front door. They keep it in admin's office. And I have not had any issues with payment with like Sunshine, the managed Med plans, and I've utilized like the samples for Med A patients, because obviously you know, that there's more cost. And I've used samples for Med-A, and it's been a long-term med, and I haven't had issues with the and that's how we've worked it out in my facility.
That's a great point, and that can be easily done. And so I am not the rep, I'm the regional director, but I still go out and sell every day. And so I don't know why all of a sudden I lost that picture. See Jennifer's iPhone. I lost everybody. What's going on? Can y'all see? Can y'all still see my screen?
I'm traveling in the middle of nowhere, so.
Okay. Can you still see my screen? Yeah.
We can see you and still hear you.
All right, perfect. So what I would like to do is, so this is a dummy screen, a dummy, we call it a sandbox version of what you would get. So I will put the office on the portal, and the MA will have access for all the prescribers. What happens is everything, all the back office work is being done by our pharmacists at the hub we have in Orlando, Florida, and the techs that we have down there. And what they do is you submit a start form for a patient, the diagnosis code, number of units, the insurance demographic information, and the closed office note. In that office, what they're going to do is they're going to adjudicate all the prior authorizations that will be needed, even if an appeal is needed for the patient. They do all that for you and have the medication kind of waiting in queue with what the copay would be. You decide when you want to have the patient have the medication, right? And we want to have it delivered to the nursing home, or if it's or to their home, if it's a SNF patient. But what we do is this: we call this, and this is kind of going back. You guys heard me talk about in the beginning, you know, the fluid management plan. So just somebody take a note. Ed said, have a fluid management plan. No Hail Marys. Fluid, which is this, right? I'm going to press it here, and let me see. It's going to say type of review. See something that says coverage and copay determination only. Do not contact patient. What it does is it allows the techs, they can go through with the insurance, and they can adjudicate everything that needs to be adjudicated, but never call the patient and never charge the patient, never do anything except it gets approved. And you'll see a prescription on your portal that will show cases, and it will just show here, and it just show release order. See what says release order right there? You decide when you want to have that order released. But they do all that work, them and the rep on the back side, and nothing's done until you guys press that green button that says release order. This is great because what it does is, you guys probably already know, I know Dee knows, probably 17 Miss Susie's of the world who always get in trouble, who's always in fluid overload. So what you do is have them, you put a list of people in the system, run it. Out of 17, you're probably going to have maybe 2 that won't have a great copay. For the 2 that don't have a great copay, we actually can provide samples for that patient as well, enough for a full course of therapy, 4 samples, so no one goes without, right? And so we do that. It gets run with the MA and the rep. They kind of work on that, and then you decide when you want them to have it. Here's what we try to do. Again, going back to proactivity and prevention. As the patient is eubulemic, that's the best time to train them and talk to them about it. And the staff, right? If they're not eubulemic, use it now. But when they feel better, they're more conscious. Train them and teach them, especially a SNF patient. And so when they get in trouble, which may not be for 6 months, remember, there's a 2-year shelf life on the medication. They know how to use it, right? And so the goal would be they don't show up in the ED or in the hospital, or they don't have to be transported because they've gotten so far going in the nursing home, paying that transportation costs, right? Risking inborn infection, risking all kinds of falls, all kinds of other issues because they have the medication now. So this has been a game changer. In Jacksonville, where you live at, so Baptist has adopted this full board. Believe it or not, Mayo uses this device. The VA in Jacksonville uses the device, but it gets shipped from the VA down in Gainesville. So it is, it's tailor-made for what y'all do. It's tailor-made, but the thing about it is we got to make it simple and just allow us to have a meeting with the MAs, and we can train the MAs live or via Zoom when I have all the stuff with me and just kind of walk through. And I cover every part of the region that you have. I cover all of it except for JT's little carve out over there in about Austin, but JT's already on board with everything now. But I cover Mississippi, Alabama, and Puerto Rico, and all of Florida too.
All over the place.
I'm all over the place. I want to go home. I'm doing a conference. I'm going to do the conference in front of the beach this weekend. The UF conference. Yeah, always working. need a raise.
This was asked already, but once the device is actually applied, how long does it stay on for?
5 hours, 5 hours. So, and it's gonna be a slow, so they won't urinate right away. It's about 45 minutes to an hour till they start to go pee, right? For 5 hours, and that's because you want to offload that fluid and like reduce that risk of hypotension for the patient. Again, with CKD, the only thing is they have to be able to produce urine. They can produce urine, they can use it, even the ESRD. You got probably you would know because you work in cardiology. So my first two patients at Baptist Heart at the beach, Dr. Galani, Rupa Galani, you know him, right?
Mhm.
My first two patients from him were extreme Alzheimer's in hospice. And he was like, I love the product, Ed, but I probably shouldn't because they probably shouldn't be alive anymore. But it kept those people alive for 6 months.
Yeah, keep them
You know what I mean? Yes, yeah, for 6 months. He was a game changer for them. And so and it's just grown. Yes.
How many times can you use it like back to back, or like what's
Great question. Great question. So our indication is to mimic a hospital, so you can use it 7 days in a row with no issue.
once a day?
No. So it's up to you. There are some providers that do BID. It depends on what I would tell you, what you would probably find. So I would say the presentation of the patients are different. A HEPFR versus a HEPREFR. HEPFR, big, bulbous patients, a lot of fluid. They sometimes do BID. There's some providers that do 2 at one time. It just, you can do whatever you want to do, but it depends on where they are. But usually 4 or 5 days in a row, usually is going to be enough to kind of get them at euvolemic. But what some people do for HEPF patients, Andrea Penario, who is a nephrologist, she works at every hospital, but she's downtown Baptist building. She would do PRN for some of the HEPF patients, just once a week, because you're always going to be so residual fluid there, or twice a week. Go ahead and run the device itself, because now again, you're being preventative and proactive for that patient. So yeah, there's no limitations when it comes to that. Yeah, but most people do really, really well. The most I had a person lose for HEPF was Dr. Carrasquillo, who's over at works for the Memorial on University. Had a HEPFer who lost 40 pounds.
Yeah,
they loved it. So, but yeah. No
so it's really kind of provider discretion. If you get great response from just one application, you can stop there and keep an eye out.
Yeah. Yes, ma'am. You want to measure like their goal weight or dry weight versus where they are right now, and use that as your measuring stick. For most people, if we catch them earlier, you should be able to get them with 1 or 2 days. Most people.
Okay, perfect. Thank you.
All right, let me get them. Can I come back on screen?
Yeah.
All right.
Y'all have any questions for him?
I know you said you have all of Florida. I'm over in I'm the regional director. I'm Whitney for the Tampa area. Is there a rep or someone I should contact for out here or can you share their information with D, or D can share my information with you? Because I've got several people in mind that this would be excellent for. We're actually starting we have a heart failure program starting at Sun Terrace that's sort of in its infancy, but I would love for this to be part of our protocol. So
she's the best rep in the company, by the way. Right now she's in Poland still. She's seeing family back. She's from Poland. But what we can do is this: you can send me an email with all the locations and the regional director's phone numbers and emails. I'll come see you and set you up. So I do it all the time. So I told her I was going to help her out. Anyway, she's not back for another week. I'll come see you.
And that's okay. You don't have to rush over here.
No. I go to Tampa. I go to Tampa like all the time for her, and I go to Orlando. I have a rep in Tampa, Orlando. I rep in Naples, rep in Miami, and rep in Jacksonville. That's my Florida reps. Then I have one in Mobile that covers all the way over to Pensacola, that portion. Then we have JT. So no, this is what I do. I'm in Puerto Rico to help a rep out here. So no, I don't mind doing it. I got time next week. So because my thing would be, so when I was sitting here talking to the VA, which always has a very, very high readmission rate, I said, we're sitting here talking, And you have the medication that you can try, and we're kind of going through bureaucracy. How many folks are going to be discharged today from the hospital who is CHF who don't have a tool to prevent the readmission? About 25 might. So that's kind of the point. So I'm not going to not let her not being able to be here hinder her and hinder you guys, because you need to see kind of how it works and the power of it. And to me, it's a game changer, because once you see how easy, how well it works and how it's tailor-made for what you do, you're going to love it, right? So no, just if Dee can see me, it's an email with everybody's the physical location address. Let me put my phone number in here in the chat and my email address for y'all. So here.
Hi, can I ask a question?
Yeah, 1 second. Let me get my iPad working for this text real quick. Okay. Phone number. Who that with that cool hat on right there? Or should be in there. Go ahead and ask the question. I'm sorry.
Yeah, you said one dose is for 5 hours, correct?
That's how long it lasts. Yes, ma'am.
So when is the next dose? How long can we give the next dose?
Okay, that was great question. So one dose is meant to mimic 1 day of stay in the hospital. It's going to depend on your patient, right? So say my patient is 200 pounds right now, but their dry weight is 185 pounds. So it's their goal weight. So they may lose 10 pounds. They lose 10 pounds. You can decide if that's enough and put them back on orals. Or not, their dry weight is 180 pounds and they're 200 pounds. You may say they only lost 10 today, I want to lose at least 5 more. I do it again tomorrow for that patient. Usually 1 time a day. You can do BID. Just going to depend on the patient and how much they're overweight. If they're overweight, and I can't tell you how to prescribe, but I'm going to give you a scenario. If they're 35 pounds overweight, you might want to do back to back. That makes sense? Or
so
twice
when we do twice a day, there's no certain time or gap.
There's no certain gap, right? You can do twice a day a couple ways, right? There's some providers that do twice a day. They may do Umex as the one and then Furoscix at the other one, or vice versa. But no, there's no gap. There's no gap.
And another question, can we use it for people with just lymphedema without CHF, without heart failure?
So it's a great question, right? So that's where the pharmacy comes into place, because we've had that get approved at $0 a lot. Because what happens is the whole label for furosemide itself changed to edema due to those cases. But that's where we're talking about that fluid management plan, right? And being proactive. You let us get the inmates on the portal, you put all those names in, and let the insurance people do their thing. And then what happens is you'll see what's been approved and how much, and then you'll know if it's a person who we can't get approved because it's just a label issue, then we'll get them samples. We'll get them samples over there, either from the rep or sometimes the company get them samples. So we'll make it work. That's why I love this, is because we're small, we're growing so fast. Sometimes we can't always keep up with samples. So when we get these plans ahead of time, we'll bring you what we have, get them ahead of time, and we kind of know there's 15 people from this site, and 12 of them have $0 copay or $4 copay. 3 we can't get covered, so we got to make sure we find 12 samples to get over to the facility, and they will be for those people that don't have good coverage. Does that make sense?
Yes. And I guess that my
Yes,
last
ma'am,
question is, I came in late. So is there any contraindication for this medication?
Great question. So the contraindications would be anuria. They can't produce urine. They can't use the medicate. They can't use the medication. And also would be a person who's just allergic to furosemide itself, and person who's allergic to medical adhesive. It's not latex. It's a 3M adhesive, but if they're allergic to 3M adhesive, they can't use it.
Oh, so but medically nothing. Like everyone that has edema can use it.
Yeah, there used to be
Yeah.
there used to be an issue with cirrhosis and ascites, but it was a language issue that's not there anymore. Now, one thing I do get this question, so no one asks this question. Someone asked, what about a person who said hep pepper, who has a bunch of ascites, right? Remember, right, what's the great thing about sub-Q is you're going right to the capillaries, right below the surface of the skin, so that's not an issue. I've had patients, as a matter of fact, Sister Immaculat's had patients that were third spacing, and you can see fluid on the floor leaking from their ankles. Work phenomenally because you're going right to the capillaries. And so, but that's a person who's been in trouble for a while. You know, we'll help them out. It's like, hey, they could have caught them earlier. So no, there's not really very many contraindications.
Yeah. Have you had patients that stop them to go to dialysis?
Stop them? What do you mean?
Like because they're over fluid. Sometimes they just need to go to dialysis to get that fluid out.
Yes. So there you go. So there's going to be patients sometime. So now you missed the beginning portion of it. I'm going to share my screen again, guys. So hold on. Hate to do it, but I got to do it.
That's okay, Edward. She'll get a receipt of this.
Okay.
Just
Yeah, I think they're
Perfect.
recording it.
we are.
There you go. So yes. So there's some people who it won't be a fit for because they have too many comorbidities and they're so delicate. But that's usually not most of the people. But the issue is you have the capacity to catch them early. So at a certain point, I always say, so when there is time to intervene, you're intervening because the person's gaining fluid. What's your intervention? You haven't had one. This is your intervention. So use your intervention early on and not later on down the road. Because at a certain point, they got CKD, they got heart failure, they got other issues, vascular issues. There's so much going on. They need to be in the hospital. But that's probably 1 out of every 25 people that's the case for.
Thank you so much.
You're very welcome. That's your cool hat. That's a cool. I like the hat.
Thank you.
You see, I'm a closed person. So, any more questions?
Awesome. Thank you so much. Yeah, we'll definitely have to set up a time for you to come into clinic here in Belfort and do like a lunch or something with the MAs and everything.
D, don't be shy. I'm gonna ask you in front of everybody. I would love to get an appointment next week.
I don't know. Typically, we're in clinics here in Belfort on Wednesday. I would have to put you in touch with our office manager because
Sure.
I don't know what our scheduling looks like around here. But I'll text you and send you Stephanie's information, and she can get you linked up.
I am. Let's see. It'd be the back end of the week. I gotta go to work in Birmingham. Look at my calendar. I'm working in Birmingham on Tuesday of next week. But anytime, say Wednesday and further out, I can meet and I could get your MA set up over there. I'll try to get the rep Jim to come and bring y'all a few samples as well. Get y'all some good fruit. Now here's a question, like, it's so funny. It's so funny. It's so funny. My cardiologist, right? All of them. Dr. Ibrahim, he's real healthy, so he's not gonna eat it. You ever have somebody bring you Potter's house? He's not gonna eat it. Ibrahim's not gonna eat it at Potter's house. But y'all like soul food?
Soul food.
Yeah.
We could probably do some soul food around here.
Yeah, okay. That's Belfort office though, right? It's not, is it at Ibrahim's office?
Yeah, Ibrahim's office here at Belfort.
He's too healthy. He's not gonna eat that.
He does. He takes good care of himself.
Yeah.
He'll be all right.
I bring some air and some water and some lettuce with no
With chicken.
So
Awesome.
yeah,
Thank you.
we'll set it up and then, but I do need you to send me the email when you can with the different regions, the regional directors and the office addresses on those. And I can start planning my schedule out to kind of help out. Because yeah, especially Tampa, that's a huge hub. We're actually about to do a direct buy with Tampa General Hospital down there too. But I need to get it because she's out of the country for another week or so. And I want to make sure that we don't go without because it's about to be this big last holiday, summertime push and high admissions. So let's keep people out of trouble.
Awesome. Well, thanks so much. I
All right.
appreciate your time.
Thank y'all. Y'all have a great
one.
rest of the week.
Thank you so much. Look forward to
Okay.
talking with you.
All right. Bye-bye.